Our guest speaker is Dr. Sagar Lodia from Emory, Atlanta. He will be lecturing us on multiple myeloma. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Janssen Oncology and Pharmafer, managed by Mice Ideas. I thank Team Janssen, Team Pharmafer, Rajesh Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group. Our guest speaker this evening, Dr. Sagar Lodia from Emory. All you discussants who are very eminent hematologists and medical oncologists, and you participants for sparing your Saturday evening in large numbers. We have over 400 registrations, majority from India, but almost 100 from outside India from 14 countries. 2/3 are seniors and 1/3 of you are fellows and trainees. So thank you so much for registering for this very, very important event. Discussants who are present here as faculty are from various parts of India, from Bangalore, Delhi, Mumbai, Ahmedabad, Jabalpur, Ludhiana, Tiruvalla, Varanasi, and Anand. To introduce them, we have Dr. Sharad Damodar from Majumdar Shah Medical Center, Bangalore, Dr. Dharma Chaudhary from BLK Super Speciality Hospital, New Delhi, Dr. Chepsy Phillips from Believers Church Medical College Hospital, Tiruvalla, Dr. Bhausai Bagal from Tata, Mumbai, Dr. Akanksha Garg from GCRI, Ahmedabad, Dr. Shilpa Prabhu from Majumdar Shah Medical Center, Bengaluru, Dr. Sunit Lokwani from Shelby Hospital, Jabalpur, Dr. Rintu Sharma from Dayanand Medical College, Ludhiana, Dr. Amit Agarwal from Homi Bhabha Cancer Center, Varanasi, Dr. Akhil Kapoor from Tata, Varanasi, Dr. Alkesh Patel from Ramanbai Patel College of Pharmacy, Anand, Lieutenant Colonel Dr. Ashok Meshram from NIHS, Aswini. It's my pleasure to introduce Dr. Sagar Lodia this evening. You have heard him multiple times. He has been our guest speaker in India as well as on webinars at multiple occasions in last 5-6 years. His formal introduction includes that he is Chair and Professor, Department of Hematology and Medical Oncology, Annie and Bernard Gray Family Chair in Cancer, Winship Cancer Institute, Emory University School of Medicine, Atlanta, US. He's a wonderful personality, a very big name in the field of myeloma, which he has been researching and treating for last 3 decades. He's authored and co-authored over 400 peer-reviewed publications. He serves on the editorial board of JCO Leukemia. He's the myeloma editor for Clinical Lymphoma, Myeloma, Leukemia. He's the hematological malignancy section editor for the journal Cancer. He's an invited and ad hoc reviewer for several publications, including prestigious Blood, Hematologica, Clinical Cancer Research, NEJM, and others. Recipient of large number of awards, just to name a few of them: Giants of Cancer Care Myeloma Award category, Onclive 2020, Millie Pub Club Award, Emory University School of Medicine 2015 and 2020, and various others. It's my indeed great pleasure to invite him to deliver his talk this evening on multiple myeloma, various important aspects. Thank you, and over to you, sir, Dr. Lodia.
Thank you very much. I appreciate the opportunity to be here today to, I think, go through some important data in terms of paradigm shifts in myeloma and where we're going as a group, and then, of course, to discuss some of these with your esteemed faculty as well. So I want to start off wishing everybody a happy Diwali. I know it was a busy and exciting weekend, spending lots of time with family. Here it was a little quieter, but certainly an important occasion for many of us here in the US as well. So I'm going to start off covering a couple of simple things to level set, if you will, in terms of definitions and how we think about plasma cell disorders across the board. So we know that about 4 or 5 years ago, the International Myeloma Working Group redefined what it means to be multiple myeloma. And unlike other diseases that require pathologists to define a given malignancy, in myeloma, because so much of what we do is based on clinical criteria, we actually created a group of about 120 people, the working group, that looked in a very rigorous way of trying to redefine multiple myeloma. And the old-fashioned criteria, including the CRAB criteria, continue to remain. So the idea of end organ damage being a manifestation of differentiating smoldering and MGUS from symptomatic myeloma continues on. However, there were 3 new criteria added to the definition of symptomatic myeloma, and these are what we call biomarker-driven criteria. And the working group, prior to the adoption of these 3 new biomarker-driven criteria, set thresholds for what the risk of myeloma within 2 years needed to be to add this to the new definition of symptomatic myeloma. And as you can see, it's 60% plasma cells in the bone marrow, serum free light chain ratio greater than 100, or more than 1 focal lesion as detected by MRI, and actually we would add PET to that as well. So just to give you a sense for what that looks like, you can see here those 3 biomarker-driven criteria. If you had more than 60% plasma cells in your bone marrow, what you can clearly see is that your risk of progression to symptomatic myeloma was very high in a short period of time. The same if you had a serum free light chain ratio greater than 100, your risk of progression to myeloma was almost 70% within 2 years. And finally, if you had more than 1 focal lesion by MRI, and remember, this is greater than 1 centimeter in size, so having microscopic foci of lesions by MRI doesn't necessarily count in the criteria. You can see again the risk of progression within 2 years was over 70%. And this led to the new definition, including with CRAB criteria, to what you see. Now, one of the areas that we struggle with for some time has been what to do with smoldering myeloma. And I want to spend the first few moments talking about the subset of smoldering myeloma that don't fall into these 3 myeloma defining event groups here. And as you can see from the top curves here, this is from Bob Kyle's original description of smoldering myeloma in the New England Journal a long time ago. There really are 3 groups of patients who fit into the smoldering subset. There's one group here where the risk of progression within 5 years is 50%, so roughly 10% per year. These are the ones that I think we do want to think about early intervention or trying to reduce the risk of progression. The second group are listed in the middle here. These are a group of patients where the risk of progression is 5% per year. These patients, I think you could argue, perhaps don't need intervention in the same therapeutic aspect as these do, but perhaps, again, maybe more suitable for immunologic maneuvers as well. The third group here is a subset of smoldering myeloma that actually looks like MGUS. 1% per year is their risk of progression. And I think these are people that we would all argue we want to leave alone. We don't want to interfere or intervene with these folks, particularly if they're over 65, which is the average age of a patient with smoldering, because their risk of progression really is no different than MGUS. And at least for now, there are only modest suggestions, and we can talk about this during Q&A, about approaches perhaps in the MGUS area for trying to reverse or prevent progression as well. Now, we know that free light chain assays independently can have a good prognostic role in separating out patients with a high risk of progression to myeloma versus not. And this is looking at patients with smoldering myeloma who either have an abnormal free light chain ratio of greater than 8 or who don't have an abnormal free light chain ratio of greater than 8, so less than 8. And as you can see, that there's a big difference in the risk of progression here. And this may be a surrogate for disease burden, but certainly in an independent analysis, this data set from the Mayo Clinic suggests that free light chains may be able to help us differentiate that a little bit. And this led to the original Mayo criteria that was adopted by the ECOG trial I'm going to show you in a moment, that risk stratified patients based on 3 factors. 1, bone marrow plasma cells greater than 10%. 2, an abnormal free light chain ratio of greater than 8. Or 3, an M protein greater than 3. And if you had all 3 of these criteria, you fell into the highest risk category. If you only had 2 of the criteria, you fell into an intermediate risk category. And if you had only 1, you fell into a low risk category. And this is what we used and has been used in a number of clinical trials and analyses for a long period of time. However, about 2 years ago, the Mayo Clinic went back and looked at different thresholds and different sets of criteria and came up with what I think is a much easier methodology to use that is actually even more predictive than currently what we see with the old Mayo Clinic classification. And this is really broken into, again, 3 categories. And the factors we're looking at here are bone marrow plasma cells greater than 20%, M spike greater than 2, so 20 depending upon your units. If you use deciliter, it becomes 2. And then the free light chain ratio greater than 20. And if you've got no risk factors, you're in the low risk category here. If you have 1, you're in the intermediate, which is blue. And if you've got 2 or more, you fall into that high risk category. And what you can see is that roughly 50% of patients will have progressed by 30 months if you fall into that high risk category. So again, probably a little bit better differentiation. And while the Mayo Clinic folks originally called this 20-20-20 criteria, in most of us in the myeloma community now are calling this 22-20 based on this M spike of greater than 2 grams per deciliter as opposed to 20 grams per liter. So what were the interventional studies that really began to talk about early intervention for patients with smoldering myeloma? Well, the Spanish published a trial back in 2013 that randomized patients between Lendex in red versus observation in blue. And these were patients that had high risk smoldering by the Spanish definition using flow cytometry as the main definition. They had a slightly modified and different definition than the ECOG ones I've shown you before, but they had been validated, and I think were certainly reasonable criteria that were used at that time point. And what you see is a big difference in time to progression, and in fact, the Spanish demonstrated an improvement in overall survival, favoring the use of early intervention with Lendex for patients with high-risk smoldering myeloma. Now, there were a couple of caveats for this trial. The first is that they used skeletal surveys for imaging. And we now know skeletal surveys are relatively insensitive. And so if we had used MRIs or PET scans, perhaps some of these patients would have already qualified as having myeloma. That's one caveat for this. The second thing to remember about the Spanish trial is that they only treated for 2 years. So this is not treatment to progression like we typically use for lenalidomide. This is really 2 years of interventional therapy. And importantly, I think it demonstrates that this big difference in time to progression is not progression by the myeloma definition. So it's not a 25% increase in the M protein. This is time to developing symptomatic myeloma. So this is really the important endpoint that we care about in smoldering. Increasing your M protein is really meaningless if patients don't actually need treatment. And so I think this to me was the first evidence that we really could impact people with an early intervention with limited duration. Now, MARI-V has gone on to update this data now with 6 and now 10-year follow-up. And what you see is that the difference in time to developing myeloma continues to exist here in terms of time to progression on the left. And more importantly, the overall survival difference also continues to be present over time as well, suggesting that this was not an early blip, that this difference in overall survival is in fact durable, even with 10.8 years of follow-up over time. Now, most importantly, one of the arguments that the naysayers use against early intervention is that all you're doing is inducing lenalidomide resistance. And by inducing lenalidomide resistance, you may actually impact your treatment afterwards. And what this shows is overall survival post-progression was actually relatively similar between the two, suggesting that the patients who got Lendex in blue did not have a worse overall survival once they progressed. And this is really important because the theoretical induction of Len resistance and a worse outcome post-progression was not demonstrated in this study, which again speaks in my mind to the power of this early intervention and the fact that it really is an important endpoint in the short term and the long term. Now, based on that encouraging data from the ECOG group, we actually did a randomized trial in the US that I led through the ECOG group that randomized patients with high-risk smoldering by the ECOG definition to either Len here on the top or observation. And this is now the largest randomized trial performed in smoldering myeloma to date. The Spanish trial was about 60 patients, 60 to 70 patients per arm. This was a little bit bigger as well. And in fact, what we demonstrated when you take all patients in aggregate, that early intervention with lenalidomide significantly reduced the risk of progression with a hazard ratio of 0.28 compared to observation, with a median follow-up of about 35 months. Now, what I want you to remember are really a couple of things. If you look at the 3-year progression, 91% had not progressed in the len arm compared to 66% in the observation. So that's almost a threefold increase or reduction in risk of progression. And remember this 91% at 3 years, because this is going to come up again in a moment here. Now, when we went back and looked retrospectively at the 2220 criteria, these were the highest risk patients that we saw. And what you see is that there's almost a 91% risk reduction with early intervention in blue compared to observation in red. So even if you retroactively apply the 2220 criteria, what you see is that it really does hold up quite robustly in the high risk group. It does not in the intermediate or the low risk group. And so based on this, our conclusions are that patients with intermediate or low risk smoldering by the 2220 criteria should not be offered early intervention, but patients with the high risk group, at least a discussion about early intervention with either len or lendex should be offered to these patients to reduce the risk of progression to symptomatic myeloma. Now, the Spanish went on to take this concept that if a little bit early on is good, what about more? And so they did a phase 2 study evaluating 90 patients with high risk smoldering. They all got KRD as induction therapy times 6 cycles. They then went on to early transplant, then went on to KRD consolidation, and then len maintenance for about 2 years. And so this is almost, this is a myeloma-like treatment. So the idea here is that you're taking high-risk smoldering and that you're going to try and treat them like you would treat myeloma. And their hypothesis was that this would be better than lendex, and that in fact, it could induce cures in a certain subset of patients. And so if you look at depth of response, clearly they had a very high overall response rate. There were some patients who even achieved MRD negativity in this approach here. So certainly encouraging response data. And if you look at adverse events, it's what you'd expect to see with multiple myeloma treatment. You saw infections, you saw rash, you saw cardiac events, you saw DVT. One patient actually did die with a stroke after a respiratory infection post-transplant. And so while these are not certainly game changers in terms of adverse events, if you take a group of patients that are asymptomatic and offer them a risk that they could die, that's certainly a different calculus, if you will, in terms of the potential benefit of treatment overall. What they did demonstrate, however, was that the PFS and the overall survival were actually quite good. Now, what I want you to remember is I told you in the ECOG trial of single agent lenalidomide, 91% at 36 months had not progressed. And if you look at Gem-Cesar, 92% at 35 months had not progressed. So whether you gave them len or you gave them KRD, transplant, KRD, and len maintenance, at 3 years, the progression-free survival was identical. And again, PFS here is determined or defined as time to develop multiple myeloma. And so I would argue that while there is theoretical benefit of an early intervention with more aggressive myeloma therapy, the idea that they may be more curable, to me, I'm not so sure about. And to be honest with you, I'm a little skeptical about that because genetically, smoldering looks identical to symptomatic myeloma. And so I think we have certainly studies to do to really see whether this aggressive approach makes sense. But at least at this time point, I think there remains a little bit of discussion in the community about whether a less intensive immunologic approach or a prevention approach makes sense, or whether you want to go with intensive therapy with curative intent. And somewhere in the middle are these triplet-based regimens. But again, the idea is not to give people treatment forever. The idea is to give a limited duration treatment, stop, and then see what their risk of progression ultimately is. Here on the left, you can see the goal is to not necessarily induce complete responses, but really immunologically control the clone Whereas on this side, obviously the risk is high overall responses, deep responses, but you do pay the price with more toxicity, and you could potentially develop resistant clones in this context as well. So this is sort of the controversy in the community, at least as it stands right now. Now, I'm going to switch gears towards patients with symptomatic myeloma, and I want to tell you what, show you what I think is the current standard of care for patients with symptomatic myeloma. This is a retrospective analysis that Dr. Joseph from our group did with 1,000 consecutively treated patients at Emory who all received RVD induction, single transplant, followed by risk-adapted maintenance. And I'm going to show you risk-adapted maintenance towards the end here in terms of what we do. But the reason I say it's the new standard is that with a median follow-up of now between 8 and 10 years, you'll see the median first remission is about 65 months for all patients in aggregate. If you look at the standard risk patients, it's about 78 months with continuous len maintenance. And more importantly, if you look at median overall survival, it's about 120 months. So 10 years is the expected median overall survival for myeloma patients who are fit enough to undergo high-dose therapy and transplant. And if you break that down into the standard risk, which is in red, it's even better than that. So again, this to me represents, if you're gonna do something different, if you're gonna talk about substituting one treatment for another, this is the benchmark that you have to beat. And early endpoints like MRD negativity at cycle 4, MRD negativity at 6 months, those are meaningless when we're talking about 8 and 10-year follow-up. I think you really do need those longer-term follow-ups to understand and know whether your treatment is really having an impact over what I would argue is probably best available therapy in 2020 or 2021 for patients with symptomatic myeloma. Now, what is the current state of the art in symptomatic myeloma? Well, I think triplets-based induction for most patients remains the standard of care. This was the SWOG 777 trial that established RVD as a standard of care, not just in terms of better progression-free survival on the left, but actually better overall survival. And I'll tell you, this trial is a little dated, I think, in the sense that expecting an overall survival benefit from an induction therapy trial of a young, fit patient population, I don't think is reasonable anymore. With a median overall survival of greater than 10 years, that first remission may be 5 to 6 years, but why would you expect that would have an impact on overall survival unless access was limited? Now, if you're talking about an older, frailer population, like the Maya study that we'll talk about later, that's a different discussion because many of those older, frailer patients may not get treatment at relapse. But certainly for a younger, fitter patient, if you don't see an OS benefit, but you do see a PFS, to me, that's good enough because we want to prolong that first remission to the best of our abilities overall. Now, there were a number of studies that suggested that KRD, carfilzomib with Lendex, was better than VRD. And these were small phase 2 studies done at the University of Chicago from my friend Andres Jakubowiak, done at the NCI from Neha Korte, updates from the Chicago experience. And then again, we're going to talk about the Forte trial from the Italian group, but all of them suggested that the VGPR, CR, MRD, PFS rates were better than what we saw with VRD. And so this ultimately gave rise to the Endurance trial, which was a randomized phase 3 trial evaluating VRD on the top versus KRD at the bottom. And there are two caveats to this trial. The first caveat is that these were only standard risk patients. So none of what I'm going to show you applies to high risk patients. The second is that these patients did not have transplant as part of their initial treatment. And so what you'll see is a shorter progression-free survival than I think any of us would expect to see in a group of patients that underwent transplant. And so the underlying message here is not just what is different between VRD and KRD, but more importantly, this leads to me saying that transplant continues to have an important role in the management of young, fit patients with multiple myeloma. And if you look here in terms of PFS, identical and in fact overlapping progression-free survival between the two, with a median PFS of about 30 to 36 months. Now, by my standards, for a young, fit patient population, This is not acceptable. 37 months is way too short. I showed you before, 65 months is what we expect in our RBD 1000 series. And so this to me shows you that the benefit of transplant is another 30 months potentially over what you get if you continue to exclude or omit transplant. Now, there were a lot of letters to the editor written about this paper, but at the end of the day, there really was no difference in treatment between these two arms. There was no difference in terms of alternative therapies. Some went on to transplant, some didn't. The numbers were pretty much the same in both of those. And in fact, if you notice, the biggest difference was really adverse events. If you got the KRD arm, you had a much higher risk of cardiac, pulmonary, and renal toxicity. If you had the VRD arm, you had a much higher risk of peripheral neuropathy. And based on this concept here, it tells you that these two may have been the reason why at the end of the day, the endpoints were relatively similar. In some patients, you had to stop because of neuropathy. In other patients, you had to stop because of cardiac toxicity. And at the end of the day, they neutralized themselves and both regimens were relatively similar. Now, the Forte trial, I think, is an important study, and this was presented by Francesca Gay, updated at ASCO this year, and it had 3 arms. There was cyclodex at the top, and I think one of the take-home messages is that using cyclophosphamide instead of an IMiD is inferior. There's no study where cyclophosphamide with a proteasome inhibitor is even close to using an IMiD and a PI together. So in my mind, this is the final nail in the coffin, if you will, of cyclophosphamide-based approaches in induction. The second was KRD with transplant. The third was KRD without transplant. And this is really based on the data that I showed you earlier, suggesting that KRD was better than transplant and that KRD was better than VR. And so we're going to test these hypotheses going forward. There was a second randomization here between just lenalidomide maintenance or carfilzomib plus lenalidomide maintenance. And I'm going to show you some of that data. That is a secondary endpoint. I think there are a number of important lessons, though, from the first initial presentation. So the first is, if you look at median follow-up from the first randomization, what you'll see is that KRD with transplant in blue is clearly better than KRD without transplant in green or KCD. So again, overall, transplant continues to offer significant benefit for all patients across the board with a hazard ratio of 0.54. So almost doubling the risk of having the risk of progression by using high-dose therapy and auto transplant. If you then look at the second randomization, in aggregate, almost everybody benefited from doublet, KR versus R alone. I'm going to leave that alone for just a moment because I really want to focus on this first randomization. If you then look at PFS from randomization again, in standard risk, blue is better than green or yellow. High risk, blue is clearly better than green or yellow. And then if you look at the subset of patients described as double hit myeloma, which is a bit of a moving target, but certainly represents a subset of the high risk patients, again, clearly the use of transplant offers significant benefit. And the KRD without transplant is just about as good as KCD with transplant, but both inferior to the use of high-dose therapy and transplant. So again, this to me cements the importance of high-dose therapy and transplant in the management of many of these patients. More importantly, sustained MRD negativity, particularly in the high-risk group, is much better with KRD transplant than either KRD 12 or KCD transplant. And this to me is the lesson. When we first saw this data, what was shown to us was response rates and MRD negativity. They were similar between the KRD with transplant versus KRD without transplant. But what I'm showing you is longer-term outcomes. PFS and sustained MRD negativity are clearly higher in the group that got a transplant. And this to me really represents what the value of high-dose therapy and transplant is for these patients. So while there are lots of people going around the world saying, you don't need a transplant anymore, these new regimens are just as good, your question to them should be, prove it. Don't just show me a phase 2 study. Show me large randomized trials that demonstrate not just overall response rate, but demonstrate sustained MRD negativity and progression-free survival that really demonstrates benefit in the absence of high-dose therapy and transplant. Now, the second is the KR versus R randomization. Again, you'll see in standard risk, in high risk, or in double hit, it appears that KR offers significant benefit. What I'll tell you is that in the high risk, that's already our algorithm, is to use carfilzomib and lenalidomide as maintenance therapy for 3 years. And again, I think this data bears that out and shows benefit. But in the standard risk patients with a median PFS of 77 or 78 months, here, I'm not so sure that the benefit is really worth it, certainly to get IVs for a number of years as well. I think we need longer follow-up to understand what this looks like beyond 36 months. And certainly at our institution, we have not adopted this as a standard approach for standard risk myeloma. But for high risk, absolutely, I think this PFS clearly demonstrates benefit for the doublet over single agent lenalidomide maintenance. Now let's go back to an older study that I think has been misinterpreted, if you will, in a number of different ways. And the reason I say that is that many groups have used this to say, see, you don't need a transplant. This was the old IFM study, 700 patients randomized to either RVD without transplant or RVD followed by transplant with consolidation and risk adapted maintenance. And again, remember, the maintenance in this trial was only 1 year. They only got 1 year of lenalidomide maintenance in this trial, different from what I showed you in the RVD 1000 series. Now, if you look at the initial progression-free survival, clearly better for the group that got transplant. This is what I showed you before. And many folks are saying, well, the overall survival is not benefit, so is it really worth it? Remember what I told you, because salvage therapies are so good, overall survival as the primary endpoint for an induction trial does not make sense anymore. Our goal is to prolong that first remission. If you then look at a more recent updated analysis, however, only looking at people by MRD status, if you look in red at MRD negative patients, the dotted line are people who did not have a transplant. The solid lines are people who did have a transplant. And what this suggests is that even among patients who achieve MRD negativity, having a transplant gives you a longer progression-free survival. And again, if you look here, the median has not been reached now for the MRD negative patients with about 85 months follow-up, 89-month follow-up. And so again, it's not just depth of response, it's sustained MRD negativity and PFS duration that really matters. And so it is important that even in the MRD negative group, having a transplant was better than not having a transplant in terms of progression-free survival. Now, what do we know more recently about the Cassiopeia study or studies trying to incorporate daratumumab into induction therapy? Well, this study, in my mind, was a little bit flawed. And what I mean by that is they certainly did ask an interesting question. Dara VTD versus VTD. Everybody had a transplant. Dara VTD versus VTD consolidation. The problem is what's grayed out here, which was Dara alone as maintenance versus observation. And we now know that nobody gets observation in the maintenance setting anymore. And so this, to me, ultimately ended up being a flawed study overall. They did suggest an improvement in progression-free survival here, but that's because there was no maintenance in this orange arm. And when did these curves start to separate? They started to separate at 9 to 12 months. What happened at 9 to 12 months? Maintenance. So if you don't give maintenance, you actually end up losing all that benefit you got from the transplant, as well as really good induction. And so these endpoints, to me, are very hard to interpret overall. However, what this second flawed endpoint does allow us to do is really ask an important question that really it took a long time for the lymphoma group to do in the context of rituximab. And what they showed was that if you got Dara as part of your initial induction therapy, it didn't matter whether you got it up front or whether you got it in the maintenance arm. The outcomes were the same. The PFS was exactly the same. So if you got Dara if you didn't get Dara up front, but you got it in maintenance, PFS here. If you did get Dara up front, but not, and you got it in maintenance, no difference. If you got Dara up front, but only got but observation, no difference here either. The only group that didn't do well was the group that got VTD and then observation. That group actually had the worst outcome, which suggests that Dara does offer benefit either in induction or in the maintenance phase, but not both. And so if you get it up front, that may be sufficient and you don't need to get it again. Now, what about the Griffin study? This is using, I think this is a better trial in terms of design. VRD, a VRD at the bottom, VR transplant, VRD consolidation, and then everybody got lenalidomide maintenance. And this is compared with the addition of DARA. So DARA VRD transplant, DARA VRD, DARA len in the maintenance setting. So everybody got lenalidomide. And what you'll see is that the addition of DARA upfront significantly improved depth of response, MRD negativity, CR rates, all those things were better with the early addition of daratumumab. And as you might expect, as I showed you from before with RVD 1000, the PFS is going to be much longer for this control arm here. And so it's taking longer for these curves to begin to separate. And certainly you're not going to see a difference in overall survival because everybody's getting maintenance. And it's going to take much longer than 2 years to really see that benefit overall. Now, what about the younger, the older patient population? How do we manage these patients? Well, there are a number of ways to try and modify RVD. This is data from Mass General looking at what they call RVD light, which gives weekly bortezomib, lower dose lenalidomide, lower dose dexamethasone. It's a 5-week cycle, which I can never keep straight in my head. And more importantly, the median PFS is somewhere in the 30s. Which is okay. It's certainly a reasonable approach to trying to treat an older, frailer population with an RVD triplet in the induction therapy setting. However, what I think is now the standard for patients with, I would argue, standard risk myeloma who are frail or transplant ineligible really comes to us from the Maya trial. And in the Maya trial, what you saw was dara-lendex versus lendex. Almost 350 patients in both arm. Again, primary endpoint was PFS with a number of secondary endpoints that you see here. And what you see is clearly a difference in progression-free survival. The median PFS is expected to be somewhere around 62 months, which is probably one of the longest progression-free survivals we've ever seen. There are suggestions that the overall survival is beginning to separate a little bit here. And so this is certainly really important in an older, frailer population here. And more importantly, when you look at updated responses, what you're seeing is that a significant number of patients are achieving MRD negative and stringent CR as well, compared to just lendex. And so this, to me, has become the standard of care for many of these patients going forward. And so if you look at our most recent algorithm at Emory, this is our current treatment approach for all patients. We ask the question, transplant eligible or ineligible. You'll notice there's no age cutoff here. The oldest patient we've transplanted at our center is 78 or 79, I think. I've said no to 50-year-olds before. So it really isn't about age, it's about performance status. We break them down into high risk or standard risk. If they're high risk, we offer them KRD induction, transplant, and then risk-adapted maintenance with either a proteasome inhibitor or KR as maintenance therapy. If they're standard risk, they get RVD plus DARA induction therapy, and then they get, we are pushing them towards early transplant and then lenalidomide maintenance. On the other side, you can see here, if they are transplant ineligible, we will give them RVD light. If they're high risk, we'll give them RD DARA if they're standard risk, and then continue on with maintenance again in a risk-adapted form. And our definitions of high risk are 17P, 414, 1416, 1420, and again, plasma cell leukemia, which certainly are really challenging for all of us to continue to treat overall. So I want to leave you with a couple of important thoughts. And the reason that I think this is so important is that there's a lot of noise out there in the myeloma community saying, achieve MRD negativity, and then you can think about stopping therapy. I don't think that that's the right answer with our current paradigm. And this, to me, is separating out things that often get mixed together. So there is a question about depth of response. Depth of response is, to me, directly related to induction. How effective is your induction therapy? But the duration of response is not just dependent on induction. It's also dependent on consolidation and maintenance. And this is where we really need to think about how to address resistant clones. And continuing on with the same therapy you gave up front doesn't make any sense. I think we really need to think about different approaches to try and get us to better endpoints overall. And this is where I think we need to think about effective early therapy and effective middle and late therapy to really try and prolong that first remission to ultimately cure a larger number of patients overall. And so I'm going to leave you with what I think the future is going to look like. The future, I think, is going to look a little bit like this, which is taking all of our different drugs and targets together and combining them in a alternating sequence of an IMiD and a PI with either DARA or a BCMA-directed bispecific. We may be using a CAR T instead of auto transplant. We may then use bispecifics with an IMiD potentially as maintenance therapy. And then based on whether or not they're MRD positive or negative, decide whether we're going to switch to a different bispecific in order to try and induce cures, with the goal of trying to take patients to sustained MRD negativity and stopping therapy. That's where I think we need to get in order to ultimately improve outcomes for our patients and control cost overall. So I think in conclusion, quad-based therapy, I think really is important. Risk-adapted treatment, as I described, is important. Transplant does continue to offer benefit, even for patients who are in CR. And again, I think our goal is to use the different treatment modalities we have and then ultimately stop treatment as opposed to the continuous therapy model that we currently have in order to prolong remissions. And with that, I'll stop and take questions.
Thank you so much, Dr. Sagar Lonia. That was wonderful. So now we have some of the Indian colleagues and they would like to ask you some questions. Maybe we can use raise hand sign for those who want to ask questions. Yes, go ahead, Dr. Sharad.
Yeah, good evening. Thank you for a very wonderful talk, Dr. Sagar. It was brilliant. Just looking at your algorithm, I had a query. So you are doing the quadruplet with daratumumab upfront in the standard risk transplant eligible. So why is it not being considered also for the high risk with the KRD? That's the first part of my question. And my second part is, in the standard risk who go for transplant, is there a need to do consolidation in addition?
Yeah, that's a great question. So let me take the first one. And we, I think, are outliers in our approach of not using DARA for the high-risk patients with KRD. That's really based on 3 trials. So if you look at the Alcyone trial, you look at the Maya trial, and you look at Cassiopeia, and you look at the hazard ratio when they were first presented for high-risk patients, it was 1 for all of them, which means there was no benefit for the addition of daratumumab. Now, there is more recently a meta-analysis published out of the group in Birmingham suggesting that when you put all 3 trials together, that there may be benefit for DARA in the high risk, but they're using the late analysis, not the early analysis of all 3 of those trials. And when you use the late analysis, the really high risk people have already died off and you've lost them in terms of the magnitude of benefit. So I remain unconvinced about the benefit of daratumumab in high-risk myeloma. And until I see a trial that really convincingly demonstrates that, we don't think it's worth using it in the induction therapy setting, at least at this point. So that's why we've not adopted DARA. Now, this is a controversial issue in our group. And I'll tell you, our group is about 9 myeloma docs. And so getting everybody to agree on something is not so straightforward. And on this one, we're split 4 to 5. So it may change after ASH this year. But certainly as of now, I think we're continuing to be skeptical about the benefit of DARA early, when KRD may offer most of that benefit, and perhaps using DARA later on in salvage therapy if you need it, where it may offer a significantly better benefit. Your second question was about consolidation. We in the US do not use consolidation at all. And that's because I think all the CTN trial that randomized people between tandem transplant, consolidation, or no consolidation and just len maintenance, the PFS was identical between those 3. And so if you give VRD upfront or KRD or even a quad upfront, I don't think consolidation really offers any benefit. The European trial that showed benefit, the EMN trial, they used VCD. And remember, I showed you before, VCD is always going to be inferior. So if all you can do is VCD, then 2 transplants may be necessary and consolidation may be necessary. But if you're using an IMiD PI up front, I don't think there's any benefit for consolidation.
Right.
Yes,
Thank you so much, Dr.
Okay, Dr. Sagar, I have one.
Yeah, go ahead, Dr. Dal.
Yeah. So in the 411 translocation, you said the PI maintenance. So is it the K or the bortezomib, which can be given subcut as a maintenance?
K, we're switching to K. It has been bortezomib in the past, but now with KRD up front, we're using K. And that, I will tell you, that's a little soft data. So that's really based on the old Arkansas experience using PIs as maintenance for 414. Most of the 414s fit into the truly high-risk group, and so they end up getting triplet maintenance. But there's a very small subset of patients with 414 who may have ISS stage 1 or 2 disease. And for those folks, if they don't have other high-risk features, we may use a PI alone.
Okay. The question that I had from the discussion you had earlier is that if you are not using DARA upfront for high-risk patients, and as you had mentioned, the DARA should be used somewhere. So will you put that in the maintenance?
So we're not doing that as of now. So the KRD up front with KRD in the maintenance and consolidation phase for 3 years is our current standard. We're now looking to see how many patients we've lost with KRD in maintenance and whether some of those patients could have been salvaged. And so we may find a subset of folks that we're adding DARA in the maintenance setting to, but as of right now, we're not doing that. What's really quite interesting is Ajay Nuka from our group actually has a phase 2 study of CAR-POM in maintenance after transplant for high-risk myeloma. And I will tell you, I think as of now, nobody's relapsed. I mean, it's pretty impressive in the high-risk group to be able to use these really potent drugs. And so there may be even better than KR in the maintenance setting. We need to look at that. We need to look at that analysis with longer follow-up, but certainly we've got 30 or 35 patients, I think, right now, and everybody's done remarkably well.
And all the trials which include DARA in the maintenance, DARA is for 1 year?
I think it varies by trial. In the Griffin trial, you continue on DARA-LEN. I think it's beyond a year. I'd have to look at that one. Most of them are not just limiting to 1 year, though.
Okay. One question from the audience. This is about dexamethasone. Should dexamethasone be discontinued in a newly diagnosed myeloma after 4 months? Does it really contribute too much to the efficacy beyond 4 months, or it's only toxicity?
Yeah, so that's a great question. And I think one of the first benefits of a quad is that you don't have to give full dose of everything forever. And so while I start with full dose dexamethasone early on, because it may alleviate symptoms or side effects of your induction, after a couple of cycles, we almost always start to cut the dex down. And at cycle 4 is when we collect cells and go to transplants. So beyond that, we don't use a huge amount of dex. Remember, dex makes len better. So if you're going to cut the dex out, you're actually cutting the response rate for lenalidomide in half. And so we do think there's a role for some dex, but reducing the dose and trying to mitigate side effects to make that more tolerable. Usually by the end of 1 year, we've stopped dexamethasone, but certainly in the 4 months to 12 months, we may just slowly taper the dose down.
One more discussion about what Sharath asked you, no consolidation versus consolidation. And you said in US, we don't do it. If your response after transplant is VGPR or sometimes less than VGPR, what do you do? Will you give consolidation to them?
I lost you there. I'm not.
No, we had a discussion that
out.
there will be no consolidation in US in general. After transplant, no consolidation. Can you hear me? Are others able to hear me?
Yes, we are hearing, sir.
Okay.
We are listening.
Dr. Sagar, can you hear us?
Yeah, now I got you. Okay, now you're back.
Okay. So the question was, Sharath asked you about consolidation, and you mentioned that in the US, we don't give any consolidation.
Yeah.
So if your response after transplant is not excellent, even if it is less than VGPR, those patients, do you give a couple of cycles of consolidation?
Yeah, so that's a good question. And depending upon the situation, probably yes. So if they're in VGPR or not in CR, we may give consolidation to those patients to try and deepen their response prior to maintenance.
Okay.
But that's not very many, to be honest with you. When you're giving a quad up front, that's almost everybody's getting a VGPR.
Right. Dr. Philip, your question.
Thank you, Dr. Sagar. It was an excellent presentation as usual, always. I had two parts to my question. First was regarding your data that you showed on high-risk smoldering myeloma. Impressive 91% PFS you mentioned at 3 years. My question was, in those who progressed, what was the strategy used for them? Was there any concerns regarding stem cell collection on those who progressed? That was one part of the question. Second was, in term, I saw your algorithm, the Emery algorithm, and you have differentiated between 414 and the other high risk, PI maintenance alone for your 414. So my concern was, in case you're not able to give the dose of lenalidomide upwards of 10, if the patient is not able to tolerate beyond 10, does that affect the outcomes? Or will you suggest addition of DEXA in those patients on whom we are not able to max the dose of len? And second is, how do you react to biochemical relapse?
Yeah. So the first one was about high-risk smoldering. So the recommendation from our group or from the paper is only to give 2 years of therapy. And as you saw at 2 years, very few patients had progressed. And so many of them, you can add len into their induction therapy if they develop symptomatic myeloma. We've not had issues there. In terms of stem cell collection, we recommended that everybody collect stem cells after 4 cycles of therapy, even during the smoldering phase. So that in our center, everybody collected at cycle 4, but many of the community centers, they didn't do that. And so you're right, more than 2 years of len is going to make it hard to collect stem cells. And that's why we suggested that everybody collect early. And I think both the Spanish group and our group are making that recommendation as well. The second one was about the dose of len. Is that correct?
Correct.
Yeah. So I actually don't go above 10. I never go to 15 in the maintenance setting. It's not clear that there's a dose response in the maintenance setting. And my approach for len maintenance is, if you can give less for longer, that's better than more for shorter. And so I don't have any hesitation reducing the dose to 5. I don't have any hesitation in going to every other day or 2.5 milligrams as well. I'd rather keep them on a little bit. And I don't like adding dex, because to me, the whole point of len maintenance is activating immune function to prevent relapse. And if you give dex, you're probably counteracting that to a certain extent. So I don't like to add the dex in. And what was the third one?
How do you react to biochemical relapse?
Oh, biochemical, yeah. So biochemical relapse, and our group differs on this as well. So patients that have standard risk myeloma that have biochemical relapse, I watch them. I don't jump in and treat them immediately. The extreme example I can give is a guy that I waited 11 years before he needed treatment, because he just slowly progressed without any anemia, without bone lesions, without anything else, and he did fine. So I think if they're high risk, biochemical is of concern. If they presented with renal failure or amyloid-like symptoms, then if they have biochemical relapse, I'm going to treat them pretty early. But everybody else, I watch them monthly to understand what the slope of that progression curve looks like. And if I'm nervous, I may get a PET scan to make sure that I'm not missing occult bone disease. And that happens about 20% of the time. They'll have bone disease even with a very, very small M protein. And if they do, then I'll treat them right away at that point.
Thank you.
Again, one question on that. If there is one just single lesion picked up on this follow-up PET scan, do you just give a radiation to that area, or you'll go full blown with the treatment again?
Yeah, that's always a tough call. I think that we have seen patients who are in MRD negative CR post-transplant who have one small area that shows up on the PET. And if that's an area where they previously had disease, I may actually watch that, because a PET will pick up bone that's healing as well as bone that's active with myeloma. And I may repeat the imaging in 6 months and see whether that's getting better or getting worse. In what you described, if they have a single focus of relapse, I'm nervous to just let that sit because we know myeloma is a systemic disease, and the likelihood that that one area in the bone in relapse with biochemical progression is the only site is pretty small.
Thank you. Dr. Rintu, your question.
Thank you so much, sir, for enlightening us with your talk, sir. And thank you for this opportunity. I would just like to ask about a subset of patients in multiple myeloma that have been usually excluded from from most of the data, like patients who present with renal failure. So in patients of multiple myeloma, what is your, who present with renal failure, what is your take on plasma exchange and high cutoff dialysis? We know that DULAT trial and most of the recent randomized trials have disregarded their role. But what is your take on this? And do you advocate the use of daratumumab in these patients as it is not renally excreted?
Yeah.
And your preference among SCI-body and renal modified doses of RVD in these cases?
Yeah. So I'll go on record as answering the last question first, which is I don't like VCD. I don't like cyclophosphamide in newly diagnosed myeloma. It's not clear that the cyclo adds anything over bortezomib and high-dose dexamethasone. And it does take a genomically unstable disease and perhaps makes it worse. We have data from Compass showing that PFS and OS for patients who get VCD is worse than VRD, and that the mutation burden at relapse is 10 times higher. So I don't like using cyclophosphamide. You could tell that in my talk. I don't like cyclophosphamide, but I certainly don't like it as part of induction. In the relapse salvage setting, it's different, but up front, I don't like to use it. In terms of the dialysis and plasma exchange, if you give bortezomib, high-dose dexamethasone, and DARA, which we have a trial currently testing that, you actually probably don't need plasma exchange in most of those patients because the responses are so quick. At our center, if somebody comes in with a very rapid acute renal failure with a high light chain burden, if we exchange them, we just exchange them once or twice and then stop, with the idea of just trying to give the kidneys a little bit of a break while we're starting bortezomib, starting high-dose dexamethasone. And in our current trial, we're adding in DARA plus bortezomib and dex for patients who present with renal failure. And every patient has come off dialysis and actually reverted back to normal or close to normal. Okay. So I think with our active drugs, and I think DARA is one of those active drugs, as you raised, I think if you're going to do plasma exchange or that high cutoff filter, you only need it for 1 or 2 sessions at the most, and by then your therapy should have already kicked in, and hopefully you don't have to keep doing it. That's our approach.
And dose use of daratumumab is same as used in the patients presenting without renal failure.
Yeah, you're right.
Okay.
It's not renally excreted, just like every other monoclonal
Yes,
antibody. There's not the label in the US does not say renal failure. And so our trial, we hope, will help to get that data out there. I think we've treated 11 or 12 patients so far. And again, the data has been remarkable at how quick and how good the renal recovery is.
Okay. And another question is, how do you approach double hit and triple hit myelomas? Do you have any different approach? And do you still advocate tandem transplants in these high-risk myelomas? Especially when we have some like really good drugs like KRD and other.
Yeah, we don't use tandem transplant at all. And so, I think the Forte study didn't use tandem transplant; they used single transplant. And so I think the idea of KRD induction, transplant, and KRD consolidation and maintenance is, I think, sufficient. Whether DARA adds anything to that, I think, is unclear. But again, the European trial that suggests tandem transplant is good used VCD induction, which we know is suboptimal, and they didn't use KR in the maintenance setting. They used LEN for the most part. And so if you can't give optimal therapy up front and in maintenance, then tandem may offer benefit. But certainly at our center, we haven't, I think the last tandem we did was probably 7 or 8 years ago.
Thank you. Thank you so much, sir.
Thank you, Dr. Rintu. Again, going to the audience, there are a lot of questions related to pomalidomide. It's so easily available in India and cheap. They all want to use that upfront for all these double hit, triple hit, high risk. What's your suggestion?
I'd like to do that too. We can't in the US. And so I think the ability to look at either KPD induction or VPD induction is something that I think you all are uniquely positioned to do. I'd love to see that data because I think certainly for 17p deletion, pomalidomide is probably a better drug. and it's a more potent immune activator than lenalidomide is. So I'd love to see your community do that kind of a trial to really show the world what POM can do up front in newly diagnosed myeloma.
Thank you. The other question related to DARA during maintenance. Those patients who get this very often have gamma globulin levels which are very, very low.
Yeah.
Do you get worried about it?
Yeah, so we don't prophylactically give people IVIG based on just a low number, but we're certainly seeing patients with recurrent sinusitis, bronchitis, pneumonia in chronic DARA administration, which is part of the reason why I'm not crazy about it in the maintenance setting. I think it's a better induction drug than a maintenance drug. And so if they have recurrent infections in a short period of time, we may add IVIG for 6 months and see whether we can reverse that, but we don't treat just a number to give IVIG.
Thank you. Dr. Ashok Meshram, your question.
Good evening, Dr. Sagar, and thank you very much for excellent and lucid presentation. My question is related to transplant, a similar question asked by Dr. Agrawal, sir. So in patient of myeloma, patients who are PET positive and MRD negative pre-transplant, and on day plus 100 evaluation post-transplant, if you find same PET positivity on scan and MRD negativity, do you give consolidation before maintenance? That is my first question. And second is, how do you treat a plasma cell leukemia in young myeloma patient, particularly the role of CAR T cell and other immunotherapies and venetoclax?
Yeah. So in terms of somebody who's persistently PET positive but MRD negative, that's somebody I probably would biopsy. Because I think, again, the question is this a persistent resistant clone, or is this healing of that bone lesion that can be PET positive as well? And if it's persistent disease, then I think giving radiation to that spot and going on with your maintenance probably makes sense, and hope that that's the lone area of resistant disease and that you can control the rest of the systemic disease. That's probably one approach overall. The plasma cell leukemia question is a bit of a moving target. So for us, we have used, we've used VDT PACE ×2 transplant and then put them on triplet maintenance. And our outcomes are actually better than most of the published data. We have that data came out a couple of years ago in, I think, Blood Cancer Journal. I can't remember now where that journal is or where that paper is, but certainly we could do better. For the 11-14 combination, for the 11-14 PCLs, primary PCL, venetoclax alone has been underwhelming. And the data on venetoclax plus other drugs, we're very early in that process. So I don't think we have enough data to really know how to do that. But what I might think about is either, and what my colleagues are doing is KRD DARA in those patients. Again, the DARA to try and reduce the circulating tumor cell burden quickly. And then using venetoclax potentially in a maintenance setting, but there's really no data for any of this. So we're all sort of making it up right now in terms of how we use venetoclax. CAR T cells, I worry that if you don't have a good enough disease control, that CAR T cells alone may not be the answer. I mean, the challenge with CAR across the board is lack of persistence. And so I think ultimately for a CAR to be successful, it's going to need some form of maintenance therapy. And whether that maintenance is just for a year or two and then stopping, I don't think we know, but I've been a little underwhelmed by how long CAR T cells have worked in many patients. And in PCL, I think persistence is going to be really important.
Thank you. Thank you very much, sir.
Dr. Akanksha.
Yeah, thank you so much, sir, for that excellent talk. So my question is regarding the follow-up of patients of smoldering multiple myeloma. How do you follow them up in your clinic? And second part of the question is that, are you doing the genetic profiling for these patients? Like the Mayo risk stratification does not consider the high-risk genetic profile patients. So what is your approach? And do you do anything different for patients who turn out to be having the high-risk genetic profile?
Yeah. So, when I follow them, we probably see them every 2 to 3 months, depending upon how concerned I am about their, early on, I may see them every 2 months just to get a sense for what that tempo looks like. But certainly as they show that they're in a plateau phase, we may see them less frequently. The genetics are really interesting. So if you look at the ECOG trial, genetics did not impact progression to myeloma. And if you look at most large retrospective series, genetics are not an important predictor of progression. Now, there was a paper from Irene Gobriel and her colleagues in Boston suggesting it was, but that was a really small subset of patients. And they sort of picked the progressors and then looked at their genetics as opposed to taking everybody and looking at who among them are going to progress or not progress. So what I'll tell you is I think that I suspect in the end, patients who meet the high risk smoldering category and have genetic abnormalities will have a higher risk of progression. But if you're low risk and you have high risk genetics, I don't know that it means anything, because I think the genetics are only part of the story, and that it's immune surveillance and immune control that may be more important for progression. And genetics may be independent of that overall. So I think the jury's still out.
Okay. Thank you so much.
Mm-hmm.
Thank you. There are a couple of questions related to what is your preferred regime after failure of autologous transplant in a patient of standard risk who has been treated upfront with VRD. So VRD, autologous, and there is failure. What do you do?
Yeah, so if they weren't on len maintenance, then our go-to will be Lendera, like the Pollux trial, to try and salvage them again. If they had more than 18 months of remission, and this is data we're presenting at ASH this year, and I think the abstracts went online yesterday, so I can say this. If they had 18 months or more PFS after transplant, then I think Pom-Dara would be our first salvage if they're progressing on lenalidomide. If they were shorter than 18 months, then CAR-Dara is probably what we would do based on the Candor trial. But you're going to see Dara as the backbone. And the question is, do you add an IMiD to it or do you add a PI to it? And I think some of that depends on how long they were in remission and what they were on when they progressed.
Thank you. There are some questions related to the high-risk myeloma more due to 1Q amplification. Is your treatment protocol different from the other high-risk myelomas?
Yeah, 1Q is a bit of a mess in the sense that everybody thinks 1Q are the same. And there's 1Q with 3 copies, which with RVD may not be so bad. And we published data on that. Tim Schmidt from our group published data on that. And then there's 1Q with 4 or more copies. And so in my view, 1Q is sort of like 13P or 13Q deletion. And what I mean by that is it's a marker of how advanced the disease is. And 1Q amplification, typically that's worst, is with 414 or with 17P. Isolated 1Q amplification may not be as bad as we think. It may not be neutral, but it may not be as bad. And so by itself alone doesn't necessarily drive change in treatment for us.
Right. Dr. Amit Kumar.
Thank you, sir. Thank you for your excellent talk, and thank you, Agarwal, sir, for giving us an opportunity. My question to you is, if a transplant-eligible patient who started on induction therapy VRD, and suppose if he progresses after 3 cycles, what will be your treatment? You will go ahead with transplant, or you would like to give a second-line induction therapy?
So they achieved a PR and then progressed, or they didn't even achieve a PR?
No, sir. They didn't achieve even a PR.
Yeah. So if they haven't achieved a PR with VRD, then I'm going to switch to something else. And most often it's going to be something like Pom-Dara or CAR-Dara to try and salvage them. It's interesting. We've had a couple of patients in the last few years who fit what you just described, and they were 11-14 positive. And we actually ended up treating them with venetoclax dex, and all of them went into response. We transplanted them and then put them on venetoclax maintenance on the back end, and they did quite well. But I think if they progress on VRD up front and they haven't seen DARA, I'm going to want to give them a DARA-containing combination to try and get them to a PR, and then transplant them and then put them on a DARA-containing maintenance on the back end. That's generally the approach, unless they're 11-14.
Thank you.
Thank you. The other question from the audience is about the duration of treatment of a relapse disease. Do you continue the treatment that you have started like DR endlessly, or you stop somewhere and switch back to maintenance?
Yeah, so I mean, all of the trials in the salvage setting do give continuous therapy. The question is, what do you do with dose intensity? So for most of them, I'm going to stop or back off the DEX by about a year. But I will keep the other drugs on their regular schedule unless patients are having side effects. Very few trials went to a maintenance phase in salvage therapy. And so I'm hesitant to change things unless patients are having side effects. And often that will drive dose and schedule of salvage therapy.
Other questions are about ONJ. If somebody gets it on bisphosphonates, do you ever put them back on bisphosphonates?
Yeah, that's an interesting question. We would do that if they manifest with bone disease at relapse. And we might switch classes and probably use denosumab instead of zoledronic acid or pamidronate. But certainly if they have bone disease at relapse, I'm going to want to give them a short trial of something different. And that's presuming the ONJ is resolved. If the ONJ is not resolved, then I'm probably going to be hesitant to retreat them with a bone strengthening agent.
Right. Dr. Philip, your question?
Dr. Sagar, just one more case I just wanted to take your input on. This lady with 414 and an extramedullary plasmacytomas, multiple. She underwent RVD, was not willing for a transplant. 1 year of maintenance, she relapsed. We switched over to KPD, and just after 4 cycles, she is relapsed again. Offered her DARA at this instant. But even after 1 month of DARA, that extramedullary, one single site is still growing in size. So how do you manage this extramedullary multiple plasmacytomas? Is it different? And in this case, any particular suggestion you would think of?
Yeah, this is a hard case. So this was not the typical 414. This is the high risk 414 where they present with extramedullary disease at diagnosis. And so, in the short term, chemotherapy like DCEP can be of benefit to these folks, and it does shrink the extramedullary disease, but it's a tough pathway going forward. So when you used KPD, you probably used carfilzomib at 2027, right?
Yes, correct.
Yeah. So what you have left is to try and salvage her again to reduce the extramedullary disease. And I might give a cycle or two of DCEP to try and do that. And then do CAR-DARA, but do the CAR at 56 twice a week, which is a much more effective dose, particularly in extramedullary disease. And this patient hasn't seen DARA yet. So I think that's your best shot at trying to get, but do that after DCEP when you've got less disease burden. And it's almost like you're trying to maintain her with CAR-DARA as opposed to induce a response with CAR-DARA. That might be one way to try and get a response in these. But extramedullary disease is tough. We've seen some benefits with canabinostat in patients with extramedullary disease, particularly partnered with carfilzomib, not at the 56, but at the 2027 or 2036 dosing. Canabinostat's a hard drug to take, and I'm not sure how long it's going to work. These patients, I mean, she needs something like a CAR or a bispecific to ultimately, if she's going to have any kind of a long-term response.
Thank you. Thanks.
Thank you. Question from the audience regarding duration of therapy of bisphosphonates and denosumab.
Yeah, so this is another one of those areas where our group does not have consensus. So we treat at least for 3 years. For patients that are in complete remission for 3 years, we may stop at that point. And I think the benefit of the bisphosphonates in an era where you've got such highly effective therapy is probably less, but 2 to 3 years of therapy seems reasonable to me.
Thank you. Dr. Ashok?
So regarding patients of extramedullary relapse, particularly, is there any particular treatment protocol for management of a testicular plasmacytoma, which is representing an extramedullary manifestation of a multiple myeloma? So is there any role of a CNS prophylaxis in such patients?
Yeah, nobody knows the answer to that. That's a great question. I mean, I think I would radiate that spot and try and sort of sterilize the sanctuary site. I think you could look in the CSF and see whether there's any evidence of disease, but that's not a common enough occurrence that we have data on whether or not they should receive CNS prophylaxis. Prophylaxis in general for the CNS is not very good. Even in lymphoma, there's data from one of my colleagues, Dr. Ornalaya, that was just published in Blood, suggesting even in high-risk lymphoma, CNS prophylaxis doesn't really offer much benefit. So I don't think I would do that, but I would certainly look if you're concerned.
So my second question is same in case of a patient having some bone marrow plasma cells like 30% and extramedullary relapse. So do you do cytogenetics in both biopsy of extramedullary mass as well as bone marrow?
Not as routine care. I think from a research perspective, that's an interesting thing to do. And in fact, the Arkansas group has done that and published on differences in genetics between the extramedullary disease and the primary marrow-based disease. But for routine standard of care, I don't think you need to do that.
Thank you. Thank you very much, sir.
There are two more questions from the audience. One is zoledronic acid. Do you change over from monthly to 3 monthly?
Yeah, we go to every 3 months at the end of 1 year.
And can denosumab be stopped suddenly?
Not a good idea because they get sort of that brittle bone syndrome. So I think that if you're going to discontinue, I mean, people discontinue all the time, but you sort of have to figure out what the dosing schedule to discontinue is.
In a relapsed patient, is cytogenetic study helpful?
Yeah, I think we do it mostly to see whether they've gained new abnormalities. So 17p is often something you acquire over time. If you're an 1114, that doesn't go away. So you're always going to be an 1114. If you're a 414 or a 1416, those are primary translocations. Those aren't going to change. But 1q may change and 17p may change. There may be other MYC-associated translocations that tell you this disease is worse. That is worth knowing about.
Can venetoclax be used outside 1114 translocation?
Yeah, so my colleague Vikas Gupta just published a paper in Blood describing differences between a B cell phenotype of myeloma and a plasma cell phenotype of myeloma. And in that, he uses flow cytometry to describe the group of patients that are most sensitive potentially to venetoclax. And one of those markers is CD20. And there is a subset of patients who are not 1114 positive, but do express CD20 that may be sensitive to venetoclax. It's not a big number, but certainly, and in fact, we've had people send us biopsies on patients who are CD20 positive, and most of them are not sensitive to venetoclax. But there is a subset that can be sensitive. And so I would direct you to that paper by Vikas, because I think it's a really important 5-marker flow panel that can predict sensitivity to venetoclax without having to do in vitro testing.
Thank you. Dr. Khurana has put up a case of large hepatic plasmacytoma measuring 15 by 10 centimeters. What would be your approach?
So this is at diagnosis?
He hasn't mentioned anything.
If it's a diagnosis and it's not solitary, so I presume this is not solitary plasmacytoma, I think I would want to treat to shrink it before I radiated it, because that's a huge area of radiation that you're going to end up delivering. Typically, those tend to occur on the pelvis. And so unless you want to radiate the whole pelvis or the hemipelvis and impact stem cell collection and counts and all those other things, I might try and treat first to shrink it. If it's a solitary plasmacytoma, then you may want to take the hit, but that 15 centimeters is pretty big. I might try and treat that first.
Dr. Dharma? Are you there, Dr. Dharma? Okay, Dr. Sharad?
I have a unique case. Can I discuss?
Yeah, go ahead.
It's a 54-year gentleman came to our nephrology colleague with the membranoproliferative glomerulonephritis for renal transplant. And he has been treated with the 4-MPAGM with the steroid outside. And on the transplant workup, we found M band of 1 gram. And then they came to heme consult. We did marrow. It's around 10 to 12% plasma cell on the biopsy. The PET scan, no lesion, no hypercalcemia, anemia is possibly part of the CKD, and we did marrow along with the 12% plasma cell. There's a PRCA. So we put that this is MGUS, and you go ahead whatever you plan. And the nephrology colleagues say we need to treat as a myeloma because it was treated with the steroid, and the PRCA is not going to help us. So this dilemma. So they're pushing every day to treat this myeloma. And I said, this is a MGUS. There is no evidence to treat this myeloma, but PRCA, we don't know.
Yeah. So if there isn't evidence of light chain deposition in the kidney, then I agree with you. This is a patient with MGUS or low risk smoldering and so I actually just had this discussion with one of our nephrologists 2 days ago about a patient and so what they're trying to understand is what's the risk of developing myeloma after the kidney transplant? And there is a paper, I think, from the Mayo Clinic that suggests that risk is low. And the second is, what is their median expected survival? So what I'm telling them now is that in myeloma patients treated at our center, the median expected survival when they develop myeloma is 10 plus years. And what they're looking for is a 5-year outlook. And so if the patient has smoldering, they don't even have myeloma yet. I think their 5-year outlook is really good. Even if they develop myeloma, their outlook at 5 years is still really good. And so I think what I would say is this is not a plasma cell disorder that needs therapy. And that if a kidney transplant is what they want to do, which I think seems reasonable, the likelihood of benefit is pretty good. And even if they develop myeloma, the outcome is likely going to be very good.
Thank you. Thank you so much.
This was discussion where there is no light chain deposition in a kidney or with light?
Without. If there's light chain, that's a different discussion because then that's myeloma.
Then you have to first treat the myeloma fully.
Correct.
This patient didn't have light chain deposition disease.
Right.
And all the fish marker was not negative.
Right.
Yep.
Sharad, your question.
Yeah, Dr. Sagar. So 2 parts. So the first one is when there's relapsed myeloma post daratumumab exposure, where do we place the bispecifics and the CAR-T, considering that, in about a year's time or 2, I think even India will have access to CAR-T. So how do you place that in your algorithm? And the second part is it time now that we redefine the smoldering high-risk 2220 as actually myeloma and kind of look at it that way?
Yeah. So the first one, if a patient has progressed on DARA, again, it depends on what their partner was. Was it an IMiD or a PI? I'll go to the other class and use that in salvage therapy. But I like the idea of a bispecific there instead, especially because we have 3 different bispecific targets. So yes, we have BCMA, but we also have FCRH5 and GPRC5D. So I like the idea of sequential or combination bispecific targets, presuming you have immune function. And that's where the newer IMiDs like iberdomide or 92480 may actually be really important because they can activate immune function and awaken T cells to make those T cell engagers more effective. So I like that idea. CAR-Ts, I think, would be a reasonable approach as well to use in a post-DARA failure. Those trials are ongoing now, so we'll see what their efficacy is. I'd like to know that it's more than 2 years because that to me is not enough. And that's where I think the maintenance phase is going to come in. So I think ideally you'd give a CAR to debulk and then you give a bispecific on the back end for maintenance for a year. And then hopefully that would be enough and you'd get a much longer response from putting the 2 together than you would with either of them alone. Your second question about the 2220 criteria. So remember, in the myeloma working group, our definition was 70% risk of progression at 2 years, justified moving those patients into myeloma. With the 2220, very few of those patients meet that criteria. So I don't think we want to take all of them and expose them to the risk of anti-myeloma therapy when a large percentage may never need treatment. So I think we have to think about still risk adapted approaches. And the prevention idea to me, I like better because what separates smoldering from symptomatic myeloma is not genetics, it's immune system. And so if you can activate immune function and control the clone with less intensive therapy, I think that's better than coming in with a sledgehammer like you saw in the CESAR trial. But that's one side of the spectrum. I think the jury's out in terms of what the right answer is.
Thank you.
The questions related to MRD by flow. That's the only one available in India. And people want to know whether to use it in clinics.
So we use MRD assessment. We don't use it for decision making. I think it is prognostic. But outside of that, I'm not using. So the one caveat is somebody who's on Len maintenance, they're in year 3 or year 4, they're having side effects, they're struggling with getting through. If they're MRD negative, I may feel better about discontinuing even low dose Len maintenance. If they're MRD positive, I'm going to use that to say, see, you need to stay on because you've still got a little bit of disease there. So it can be useful there, but outside of that, I'm not making decisions with it.
Dr. Sagar, are you okay with few more questions?
Yeah.
All right, Dr. Akanksha.
Yeah. So I had one practical question, someone known to me. So if they were affording, she was a multiply relapsed myeloma, and she was affording both a CAR-T and belantamab, which one would you prefer and advise? Like, that was the practical query that they had.
Yeah, I mean, they're different approaches. So, I think belamaf is off the shelf and it's ready to go right now. If they have disease that can wait 6 weeks for a CAR, then I think CAR is a reasonable thing to do. I can tell you in post-CAR failures, we've salvaged them with belamaf. So it's not an either or situation. If you look at the KARMA trial, and my colleagues hate it when I say this, but the duration of response for belamaf is the same as a CAR. It's 11 months. Now, more people are likely to get into that response with a CAR than with belamaf. It's double the number. But certainly durability of response is similar between the two. And so it's a matter of what their threshold for risk is, CRS and cost ultimately will decide that.
And is there any role of CD19 expression while choosing between the two? CD19?
I'm not aware of any.
Okay.
Thank you. Dr. Rintu?
Another question related to renal failure, sir. So in patients who present with acute renal failure and they go on becoming dialysis dependent, so what is your choice for bone sparing agent? Do you use denosumab in those patients? Or do you use creatinine if modified dose of zoledronate in those patients? Or do you wait for 1 or 2 months till renal failure recovers and then you go ahead with zoledronate because of the cost issues?
Yeah. So, one dose doesn't affect the kidneys really at all. So if it's an acute renal failure that's reversing, I may give them a dose of dose-adjusted bisphosphonate just to cover them, particularly if it's related, if it's patients with bone disease or they presented with hypercalcemia. One dose is not going to make a difference. I may wait until the renal failure settles out a few cycles later to give a second dose. There's really not a rush. If you're giving bortezomib, you're actually really stimulating bone growth and activating osteoblasts and suppressing osteoclasts. So I don't feel like it is, 20 years ago when all you had was VAD. And the bisphosphonates were hugely important to reducing risk of fracture. Now I think you've got time to let things settle out and get what you need.
And another practical question, sir. Actually, few of our patients who remain dialysis dependent 3 or 4 months post induction. So some of those patients have undergone autologous stem cell transplant, and they are still dialysis dependent. Ideally, they need renal transplant. But what if they cannot undergo renal transplant in such a case? And they have myeloma and/or remission. They are in hematological remission, but they are still dialysis dependent. So do you change your myeloma strategy for those patients?
No, we'd put them on maintenance.
Maintenance.
We put them on risk-adapted maintenance. Yeah. We would do what we would normally do for them. We have a lot of these patients where that's what we do. And that's fine. I mean, I've got patients who are dialysis dependent, but are now 8, 9, 10 years out from transplant and doing fine. So I do what I would normally do.
Oh, thank you. Thank you, sir.
One last question from the audience is about delayed transplant. In India, sometimes patients are not willing for upfront transplant. Is it okay to do delayed transplants?
Yeah, I mean, if you look at the overall survival data from the IFM, Many would argue that delayed does just as well as early. What we know is that the PFS is shorter because they've had one line of therapy already. They're already a little bit more resistant. And so, yes, it's a reasonable thing to do. In the northeast of the US, almost everybody does delayed. In the south near us, everybody does early. And so I think it's a little variable, but it's certainly not an unreasonable option to offer people who delayed transplant. But know that your benefit is going to be less. That's the reality.
Any question from the faculty here? Otherwise, we're going to close this webinar. Nothing. So thank you so much, Dr. Sagar Loner, for sparing so much time. It was wonderful talk and a great interactive session. You have been always very, very kind to us. So many times we have heard you and you always obliged. Thank you so much.
Thank you.
Good day to you and good night to all of you. Thank you. Bye-bye. Bye, sir.
Bye. Good evening.
Thank you, sir.
Thank you, sir. Bye.